Assalamu alaikum friends. Actually, I wanted to present one more very important case, and it is not very common. We could say it's rare, but it is very important, and it is associated with a lot of other neurosurgical diseases. And first of all, I want to introduce myself. I am Dr. Muhammad Kazafi, and you are watching right now Dr. Muhammad Kazafi Views, and our topic is basilar invagination. And I want to talk about this topic because I was thinking that it should be presented in front of you people with thorough information, so you could appreciate and understand this is what kind of topic is that. So the basilar invagination is an abnormality at the craniovertebral junction, either congenital or degenerative, result in the odontoid prolapsing into the already limited space of foramen magnum. It is commonly associated with conditions such as the Chiari malformation, syringomyelia, and Klippel-Feil syndrome. Clinically presented, which can range from a chronic headache, limited neck motion, and acute neurological deterioration. The CT scan and the MRI are the critical to diagnosing and managing the conditions, including the operative planning when needed. Determining the need for operative intervention is controversial in asymptomatic patients, but those are at risk of the neurological compromise could require preoperative cervical traction and algorithmic surgical strategies, which could be stereotactic applications or somehow like that. So these activities this activity outline the evaluation, management, and review upon the latest anatomical basis pertaining to basilar invagination pathogenesis, and address the paradigm shift related to its surgical management. Our objective is to summarize the pathophysiology of the basilar invagination for explaining the clinical sign and the symptom of outline characteristic radiological finding among patients with basilar invagination, outline recent advances in the guideline for imaging Group A and Group B variation of basilar invagination, summarizing common complications associated with different approaches for managing basilar invagination, and how the interprofessional teams can provide appropriate coordinated care to improve outcome. So the pathophysiology, how we could understand, definitely I will show you, or I will present you, first of all, I want to give you the little introduction for the basilar invagination. Ackerman first described basilar invagination in certain this. Schauler gave the first radioimaging diagnosis, which Chamberlain and other radiologists later refined it. Basilar invagination is an abnormality at the craniovertebral junction, either congenital or degenerative, resulting in the odontoid prolapsing into the already limited space of the foramen magnum. It is commonly associated with conditions such as the Chiari malformation, syringomyelia, and Klippel-Feil syndrome. So the clinical presentation can range from chronic headache, limited neck motions, and acute neurological deterioration. CT scan and the MRI are critical for diagnosing and managing these kind of conditions, include operative planning even added. Determining the need of operative intervention is controversial in asymptomatic patients, but those at risk of neurological compromise could require preoperative cervical traction and algorithmic surgical strategies. I want to explain the etiology in that manner. The compared at the skeletal development of the other regions of the spine, the cervical spine has more pronounced change from birth to skeletal maturity, while some defect may appear static. Changes in the cervical spine are more likely to become asymptomatic and even life-threatening. The most common adult craniocervical junction malformation include Chiari malformation and basilar invagination. So I want to, and as I mentioned, it's not very common, but here this is the most common adult craniocervical junction malformation, include the Chiari malformation and basilar invagination. It is common in that regard because it's common malformation. If we are considering the most common craniocervical junction malformation, so then we should understand the Chiari malformation and the basilar invagination. Chiari malformation I already presented in front of you people, and now I am trying to present in front of you the basilar invagination. The basilar invagination is a condition where the floor of the skull at the foramen magnum has developed in such a way that the superior aspect of the cervical spine is more shuffled and even posterior, and in fact has created a narrowing of the foramen magnum opening, and this area is at risk of the odontoid prolapse, along with the decrease in surface area that places the patient at an increased risk of neurological injury or description of the cerebrospinal fluid flow. This condition can result from C1-C2 facet instability, congenital osseous defect, or the secondary to degenerative processes even seen in 20% of the patient with rheumatoid arthritis. So, as I mentioned, these conditions can result from C1-C2 facet instability, congenital osseous defect, or secondary to the degenerative process are seen in 20% of the patient with the rheumatoid arthritis. So it could be not always the congenital. It could be later with the rheumatoid arthritis, and it can cause the neurological symptoms and the signs. And so it is a very, very important to understand here. I want to represent some epidemiology in such a way. The basilar invagination is the most common form of craniovertebral junction malformation, and a study examining craniovertebral junction anomalies in young adults observed the basilar invagination to be the most common anomaly, followed by the atlanto-occipital assimilation. Why? Because the atlanto-occipital assimilation is the 33%, but the basilar invagination is 53%. It means it is 1.5 times more than the atlanto-occipital assimilation. One notable study looking at the surgically treated basilar invagination patient indicated that the Chiari malformation might correlate to age at presentation and symptoms. So those with the Chiari malformation usually present later in the second 20%, and third 44%, and fourth 24% decades of the life compared to those without the malformation. So it is very important to understand that those with the Chiari malformation usually present later in in second decade, 20% are presenting in second decade. In third decade, 44% Chiari malformation presented with the basilar invagination, and fourth one, the 24% also presented with the Chiari malformation, and in the fourth decade. So it means in the second, third, and the fourth decade, who has the Chiari malformation, he has significant chance of the basilar invagination. So here, as I want to tell you, usually presenting earlier in the first means 15% people in the first decade and the 58% in the second decade. It means every decade the different percentage of basilar invagination. So it means Chiari malformation usually associated with the basilar invagination, but it differs by percentile according to the decade, which decade patient is living. In the same manner, furthermore, those with the Chiari malformation had slower progressive symptoms occurring over a longer time, and most commonly weakness. 94% means weakness, 94% weakness, paresthesia, 80% paresthesia, posterior column and spinothalamic disturbances, 55%, ataxia, 50%. So these kind of symptoms usually people suffer with the Chiari malformation and the basilar invagination. The people are suffering for these kind of symptoms, such as a weakness, it is 95%, paresthesia is 80%, posterior column and the spinothalamic tract disturbances 55%, ataxia 50%. So those without the Chiari malformation mainly present with the weakness. 100% patient presented with the basilar invagination presented with the weakness, and 60% patient even though without Chiari malformation, only with basilar invagination, they presented with the neck pain, and solely posterior column dysfunction is 40%, bowel and the bladder disturbances about the 30%, and paresthesia about the 25%. Therefore, while none of patients with the Chiari malformation and the history of trauma just before the symptomatology, the 48% of those without the malformation noted trauma precipitating the symptoms. So this is somehow I tried to present in front of you the epidemiology. Now, as I mentioned before, that the pathophysiology of basilar invagination is very, very important. The most recent theory behind group A, the basilar invagination, is the atlantoaxial facet joint instability, therefore predisposing to upward migration of the odontoid pag through the foramen magnum and resulting in the brain stem compression. So the basilar invagination is the major problem which cause narrowing of the foramen magnum and causing the odontoid pag upward placement migration and causing some kind of a pressure over the brain stem, and brain stem has been compressed. So the basilar invagination is the result of the listhesis of the C1 and C2 facet. So the craniovertebral realignment may be considered later on, though the manipulation, distraction, reduction, and the fixation of the atlantoaxial facet joint is therefore needed, the principal mandate of surgery in these cohorts. So, a developmental anomaly of the bone is suggested by virtue and the Guards is that the pathogenesis for the group B, basilar invagination, the congenital Osseous dysgenesis lead to crowding of the posterior fossa and the compression at the foramen magnum, and narrowing of the foramen magnum is causing all these problems of the basilar invagination and the crowding of the posterior fossa. Secondary natural protective mechanism after that progresses to minimize the stretching of the cord over the indenting odontoid pag by allowing a relatively stretch-free transversal. Here, I wanted to explain you some history and the physical examination of basilar invagination patient. There is a wide array of presentation for basilar invagination, with many of them directly resulting from the syndrome. It may be associated with such as Chiarimalformation, which is suboccipital at the rate of 33% to 38%, the degree of subfold migration of the dense atlas, clivus, weightlifting, so determining the neurological sequelae, as this create significant crowding of the foramen magnum as well as at the medulla oblongata. Also, these crowding could obstruct cerebrospinal fluid flow leading to the syringomyelia, and it is the cause, and the theory is suggestive, which I mentioned in the Chiarimalformation video, that the multiple theories are supporting the same thing which I mentioned right now in front of you people. So, in the event of medullary dysfunction, a patient may exhibit ataxia, dysmetria, nystagmus, dysphagia, or cranial nerve palsies. Interestingly, these have been well documented association between exertional cuff headache almost exclusively at the occipital or suboccipital, not migraine in a pattern, and basilar invagination. In a study of 97% patient evaluated for the cuff and exertional or sexual headaches, advanced imaging noted at intracranial defects in 45% of cases, and up to 80% of the secondary cuff headache are associated with the Chiari-1 malformation. So it is very alarming and we have to be little focused over that. This is a very much well documented that the occipital or suboccipital not migraine in pattern basilar invagination in a study of almost 97 patients with the cuff exertional or the sexual headache, advanced imaging noted and intracranial defects in 45%, and up to the 80% of the secondary cuff headache are associated with the Chiari-1 malformation. So recommended that every patient with the cuff headache have a craniocervical MRI. It's very, very important. In addition to cuffing, these headaches can be brought on by laughing, weightlifting, or head postural changes. So other sometime more apparent finding, while not exclusive to basilar invagination, is a short neck and asymmetric face skull or torticollis reported in 68% of the cases. One of the frequent causes of the secondary type basilar impression is rheumatoid arthritis. As I mentioned earlier, rheumatoid arthritis also a big cause or crowding of the posterior fossa or migration of the odontoid pag to the foramen magnum. The basilar impress result from the rheumatoid arthritis was originally termed cranial sackling, when Matthew and the other interpreted odontoid migration to result from cranial descent due to eroded lateral skeletal masses. Approximately 8% of the rheumatoid patients demonstrate these changes. These changes may lead to sudden death as a result of instability and require surgical fixation. A predominant sign and symptoms in patients with the basilar invagination can be broadly categorized as follows. So the pyramidal symptoms such as the altered kinesthetic sensation or spinothalamic dysfunction, also from the one of the few of the predominant signs and symptoms of the basilar invagination. The constellation of the presenting sign and symptom include the weakness, numbness, paresthesia, neck pain, gait instability, spasticity, dysphagia, and dysarthria. Neck pain is the most common, approximately 80% presenting symptom, such as the torticollis is observed in around 40% of them, and the presentation is comparatively acute in group A, whereas slowly progressive in group B patient. Almost 80% of the patients with type A basilar invagination have a history of head injury prior to the onset of this system of the symptoms. So, as I mentioned, almost 60% of the patients with type A basilar invagination have a history of head injury prior to the onset of their symptoms. Short neck and torticollis are common in group A basilar invagination, and they also have neurological symptoms due to direct and nucleus preposis hypoglycemia lead to transsynaptic degeneration and causing disproportionate atrophy of the cerebral vermis with preserved tonsillar volume. In group B patients have clinical features related to the central cord syndrome and syringomyelia, secondary to the crowding of the posterior fossa. So this is all about the sign and symptoms, but I want to mention few things very important regarding this sign and symptoms, such as basilar invagination can be associated with other concurrent anomalies like atlantoaxial dislocation, Chiarimalformation, atlas occipitalization, Klippel-Feil syndrome, atlanto-occipital hyperplasia, clival hyperplasia, os odontodium platybasia, all are very important, and understood that the basilar invagination can be associated, one of them which I just told you before. This telescoping of the spinal segment in the event of chronic atlantoaxial instability try to confer natural protection, thereby leading to short neck, torticollis, dorsal kyphoscoliosis, Klippel-Feil alteration, C2C3 fusion, assimilation of atlas, bifid arches of atlas and axis, platybasia, Chiarimalformation, and syringomyelia. These natural protective sequelae are most often reversible following atlanto-occipital stabilization in group A basilar invagination and foramen magnum decompression in group B basilar invagination. Evaluation is very important, and it is the goal of this presentation. Actually, this basilar invagination is most often diagnosed pertaining to following mid-sagittal craniovertebral parameter: Chamberlain line running from the posterior aspect of the hard palate and posterior margin of the foramen magnum. So it is very important for the evaluation. These chamber lines running from the posterior aspect of the hard palate and the posterior margin of the foramen magnum is very, very important. The second thing is the McGregor line. It's running from the posterior margin of the head of the hard palate to the lowest part of the squama occipitalis, as the posterior edge of the foramen magnum could not always be visualized. So the McGregor lines also were very important for basilar invagination evaluation. McPree lines connect the anterior posterior line for foramen magnum. Actually, these were the radiologists, especially the Chamberlain. He mentioned these lines, and it has been pronounced after by him Chamberlain lines, which he introduced. The criteria for diagnosis are the tip of the dense line, the tip of the dense line more than 5 millimeter above the Chamberlain line, and more than 7 millimeter above the McGregor line and McRee line. So it is the criteria for diagnosis. This criteria of diagnosis should be remembered by heart, and I want to repeat it once for you again. The criteria for diagnosis are the tip of the dense line more than 5 millimeter above the Chamberlain line and 7 millimeter above the McGregor line or McRee line. So it could be the criteria of diagnosis. And the Chamberlain line running from the posterior aspect of the hard palate and the posterior margin of the foramen magnum, so you should remember. And the McGregor line running from the posterior margin of the hard palate to the lowest part of the squama occipitalis, as the posterior edge of the foramen magnum could not always be visualized. In the same manner, I want to present you based on the atlanto-dense interval, however, the type 1 and the type 2. Type 1, when atlanto-dense interval is more than 3 millimeter in adult, or atlanto-dense interval 5 millimeter, more than 5 millimeter in children. So we consider this is a type 1 basilar invagination. In type 2, when the atlanto-dense interval less than 3 millimeter in adults and atlanto-dense interval is less than 5 millimeter in children, we consider this is a type 2. So we have type 1 and type 2, and which I already mentioned, this atlanto-dense interval, if more than 3 in adults, type 1, less than 3 in adults, type 2. In the same manner, more than 5 millimeter in children, type 1, and less than 5 millimeter in children, type 2. So recently the basilar invagination has been divided into the two groups, group A and group B. Group A basilar invagination, the tip of the odontoid process is above the Chamberlain line, McRee line, or Wackenham's line, Wackenham's clival line. Then it is considered the group A basilar invagination. Means the tip of the odontoid process, it goes up above the Chamberlain line, and I mentioned you the Chamberlain line means it should be more than 5 millimeter above the Chamberlain line and 7 millimeter more than the McRee line or the Wackenham's clival line. Group B, the odontoid process and the clivus remained anatomically aligned, and the tip of the odontoid process is above Chamberlain line but below the McRee line and Wackenham's line. So it is also a division which I mentioned according to the atlanto-dense interval. It is almost similar like that. A few of the essential radiological parameters utilized during the management of the patient with basilar invagination include the clivus length and the basal angle play a role of pathophysiology of basilar invagination and the Chiarimalformation. So the clivus length and the basal angle are very, very important. They are playing the role in the pathophysiology of the basilar invagination and the Chiarimalformation. So we should know the clival length and we should know the basal angle, how they are actually. The odontoid tip either intersect the minimum perpendicular distance from the odontoid tip to the palatal internal occipital protuberance line or less than 9 millimeter below the palato internal occipital protuberance line. So this is of the goal group. Goal group also considered as a group A and the group B, which also classify in that manner the odontoid tip either intersect the minimum perpendicular distance from the odontoid tip to the palato internal occipital protuberance. So it is very, very important. If it is more than 9 millimeter, then it will come in the group B, and if it is more than 9 millimeter, then consider in the group A. So less than B and more than 9 is A. So the clival slope is the angle between the Wacken-Hammon's line and horizontal line. So a reduction in the clivus slope affect the post-operative pro-JOA score of basilar invagination patient. So these are the important landmarks, or these are the important markings regarding the basilar invagination. The foramen magnum angle between Chamberlain line and McBride line, which categorize the title of foramen magnum, in almost 22 degrees in basilar invagination versus 6 degrees in normal persons. So the 6 degrees considered the normal, and the 22 degrees can definitely consider the basilar invagination due to the clivus hypogenesis. So you should understand this is also because of the clivus hypogenesis, as I mentioned before. The clivus line violation is the most widely used indicator in the diagnosis of the basilar invagination, with the value of clivus line valuation more than 3 millimeters currently defined. So the basilar invagination usually show a decrease in clivus axis, which should give rise to the progressive neural compression. As I mentioned, the clivo-palatal angle is the angle between the Wacken-Hammon's line and the tangential line of the hard palate plane, and can be applied intraoperatively for correcting sagittal alignment. And this clivo-palatal angle showed higher inter-observer agreement than clivo-axial agreement. So this is very, very important, and that clivo-palatal angle is the angle, I want to repeat that the clivo-palatal angle is the angle between the Wacken-Hammon's line and the tangential line of the hard palate, and can be applied intraoperatively for correcting sagittal alignment. And this clivo-palatal angle showed higher inter-observer agreement than the clivo-axial angle. In the same manner, the distance of the odontoid apex to Chamberlain line and the Bogaerts angle, if more than 136 degrees, has been observed to have the highest diagnostic accuracy for type B basilar invagination. The minimum perpendicular distance from the odontoid tip to the palato-internal occipital protuberance has the advantage of diagnosing both types of the basilar invagination while comparing the Bogart's angle, and this is not affected by the position of the head. Postoperative Bogart's angle has the most important predictor of the basilar invagination prognosis. The other point is very important, that the cervicomedullary angle is in normal patient range from the 175 degrees with the average of 160 degrees, but the cervicomedullary angle is considered an effective index to assess the grade of anterior spinal cord comparison. The clival axial angle was divided by Chamberlain line into clivus tilt and axial tilt. The difference between actual axial tilt and ideal value about 95 degrees in the optimal target of the clivus axial angle correction to decompress neural element ventrally and recover better subaxial cervical lordosis. The clivus axis angle causes less than 150 degrees medullary compression, and this can be used to evaluate the decompression postoperatively. So the dynamic CT imaging helping us assess that what we say this instability, or we can say the craniovertebral junction instability, and the computerized tomographic scan also detailed pattern of the bony abnormalities, pertain osseous anatomy, facet angle, degree of the bone destruction. This also helped determine the need for C1, C2 osteotomy. The C2 pedicle in the basilar invagination is thinner than the control group, so the occipital bone in basilar invagination patient is thinner. In the same manner, preoperative CT angiogram is highly recommended to identify any anomalous variation such as the kissing carotids and the high riding vertebra and the anomalous right vertebral artery to minimize the risk of intraoperative injury. The separating, fusing, opacifying, false color volume rendering technique has been used to identify the course of the vertebral artery. Here I want to mention here that the multi-positional MRI is reliable imaging to evaluate the level of cord compression and the angle of the cord compression. So T2 and the signal changes, Chiarimalformation, and the syringomyelia you can appreciate with the help of multi-positional magnetic resonance imaging. I want to now come over here for the treatment and the management of the basilar invagination. I want to give you some little reference of the history. In 1939, Chamberlain first described the suboccipital craniotomy and cervical laminectomy and dural opening to manage the basilar invagination. However, significant morbidity and the mortality were reported following the procedure, especially for Brosha, Jester, and the Sinha, including the risk of intramedullary hemorrhages. But Sheeker advocate the use of traction for a few patients without any neurological disturbance. Clinical and radiological preoperative traction for the progression of the disease has been described as reasonable alternative to operative stabilization. The determination of approach is usually the result of the reducibility of the basilar invagination, giving the importance of the reducibility in the surgical approach. Preoperative traction is a valuable tool in determining the degree of reducibility and assessment of neurological status. In a series of surgical treated patients with basilar invagination performed by the Gould et al., the 88 patients they operated without any association of the Chiari malformation were placed in the cervical fraction, and 82% of these patients noted rapid clinical improvement after the application of the traction. So the traction can be a useful tool in evaluating the reducibility, predictability, and intraoperative neurological improvement or neurological worsening by surgical positions. So the head frame reduction technique can be applied in patients with reducible atlanto-occipital dislocations and basilar invagination. Irreducibility is defined as non-alignment of the C1, C2 during neck extension. So determining the lateral X-ray and after that the cervical traction, simple posterior fixation and fusions are the adequate for reducible craniovertebral junction deformity. In the same manner, as I represent one historical background, again I want to present one recent historical background. In 1980, Manet et al. Divided craniocervical abnormality into reducible and irreducible group. So the posterior fixation was recommended for reducible variation. Transoral decompression was followed by the posterior occipito-cervical fixation for a stable ventral lesion, whereas dorsal decompression with or without stabilization was carried out for dorsal pathologies. Transoral surgery, first used by Canavel, was popularized by the Cockard et al. With the application of retractor system and the microscope for managing the basilar invagination. Basilar invagination is the most common indication for occipito-cervical fixation, and the occipito-cervical fixation, however, has implant and wound-related complication and significant restriction head movement as well. The surgical strategies have slowly evolved from only bone overlay to sublaminar wire fixation and subsequent screw plate rod fixation from midline fixation strategies. Now the notion has shifted to facet fixation as been described by Gould and the Lahari. A reduction via anterior, transoral or posterior C1, C2 facet distraction is necessary for irreducible deformity. Posterior intra-articular distraction followed by the cage implementation and the cantilever correction can achieve a complete reduction in most cases. One-stage release reduction and fixation through the posterior approach are safe and efficient. A single-stage posterior stand-alone approach is accepted at the first-line treatment. So the posterior atlanto-occipital facet reduction, fixation and fusion, which we say AFRF, means atlantoaxial facet reduction, fixation and fusion, are also recommended for patients with the failed suboccipital bony decompression. Facets are fixed, osteotomy has been required, and anterior release reduction and the posterior fixation for irreducible basilar invagination will add a lot of support for treatment of such kind of patient, especially in patient with the severely deformed bone mass anteriorly compressing the cervicomedullary junction. So this idea is very useful. Ultimately, the approach should be made on a case-by-case basis after a thorough evaluation of the clinical findings and the radiological imaging. These have been a paradigm shift from the anterior it has been paradigm shift from the anterior and combined anterior and posterior approach to stand alone posterior surgical strategy wherever feasible. The aim of surgical intervention include foramen magnum decompression, restoring and stabilizing and the alignment of the craniovertebral junction, restoring normal cerebral spinal fluid flow dynamics. Traditionally, basilar invagination can be treated with cervical traction and posterior stabilization. However, the anterior decompression via transoral or endonasal approach may be necessary in irreducible cases. So the transoral transatlantoaxial reduction plate fixation are nowadays getting popularity in those patients which are not reduced by only traction and posterior fixation. The performance of the reduction and the decompression and earlier bone fusion rate of the transoral atlantoaxial reduction rate and procedure are superior to those of simple occipital fixation. Transoral odontoidectomy as a salvage surgery is safe and effective for inadequate decompression from the posterior distraction and fixation. Recently, endoscopic endonasal approach has been postulated and compared to the traditional transoral or transpalatal approach, and this endotracheal endonasal approach has following benefits, such as the minimal stay in the ventilator, earlier extubation, minimizing the need of tracheostomy. This endoscopic endonasal approach, negating prolonged tongue retraction and splitting of the soft or hard palate and reducing the risk of the postoperative upper airway edema and the velopalatal insufficiency and dysphagia. Earlier postoperative oral feeds and the reduced occipital stay is now a promise of this endoscopic endonasal approach. Following endoscopic endonasal approach for basilar invasion, almost 90% of the patients have shown neurological improvement, image-guided navigation, and intraoperative and CT scanning facilitate localization and complete resection of the odontoid process and decompression of the spinal cord. There is, however, a steep learning curve. Moreover, intraoperative and postoperative cerebrospinal fluid leak have been reported up to 30% and the 5% respectively for the postoperative. Intraoperative definitely 30%, but the postoperative 5%. This multi-layered closure and the mucoperiochondral vascularized flap is preferred to prevent CSF leaks. Limitations of the endoscopic endonasal approach is the limited surgical window, so a narrow surgical corridor hinders the manipulation of surgical instrument. Suturing, especially during primary closure following a cerebrospinal fluid leak, is really a challenging thing. A recent study has validated the role of the atlantoaxial facet distraction with fusion posteriorly only for a group A people, whereas the only suboccipital and foramen magnum decompression without need for duroplasty in the group B people are very much popularized and accepted, even in the presence of syringomyelia. Posteriorly, C1, C2 distraction and fixation is a safe, effective technique for the treatment of the basilar invagination, restoring the height of the atlantoaxial lateral mass by using an individual cage and adjusting the posterior occipital clavicle angle, and using cantilever technology is possible. An attempt of C2 nerve root preservation is preferred. The accuracy of the freehand pedicle screw placement measured by the Robin scale in the Basilar invagination has sometimes been reported to be below 25%, so the navigation is preferred for complex congenital craniovertebral junction malformation to improve the accuracy of instrumentation. The interarticular cage causes a folding chair effect to reduce the dislocation, and the cage can also use as the fulcrum to adjust the occipitocervical angle through the cantilever technique. The appropriate selection for the occipitocervical angle by adjusting the POCA by the shaping the rod can be undertaken, and this cervicovertebral junction alignment measured by the clivus canal angle and the cervicomedullary angle can help plan the surgical strategy. Head extension maneuver through the occipital screw and the rod system for the craniocervical realignment is very common. Posterior decompression alone without duroplasty in type 2 basilar invagination releases local compression, and it can be decompressed, but alleviative posterior crowding and promote ventricular flow. But in the same manner, we have to consider in the re-evaluation of the patient and review of the patient. Here I want to present some differential diagnoses which are very much behaving or similar like that, which is the platybasia, basilar impression, and rheumatoid, because of the rheumatoid arthritis, because of the Paget's disease, because of the osteomalacia, because of the hyperparathyroidism, because of the osteogenesis imperfecta, because of the Huller syndrome, because of the rickets, because of the skull base infection. So it is very I think noticeable differential diagnosis here. It is postulated that the basilar impression is due to recurrent microfracture from the repetitive axial load, and supporting this theory is intraoperative finding of proliferative callus at the base of the skull in patients with osteogenesis imperfecta. One study showed that 25% of patients had this effect, and even if treated secondarily, basilar invagination potentially has devastating sequelae in osteogenesis imperfecta patient and other osteochondro dysplasia such as the Hagdu-Cheney syndrome. The prognosis, while surgery can improve some neurological symptoms and a complete recovery is not always possible, residual neurological deficits are common and in some cases may be disabling. But the complication may be, for example, complex regional osseous anatomy, severe obliquity of the C1 and C2 facet, abnormal osseous fusion, and the presence of extreme facet arthropathy and contraction of the tissue can hinder the realignment process. The main limiting variable in reducing here is that the atlantoaxial deformity and the basilar invagination are that anterior atlantoaxial tension bands and the lateral articular process deformity also hinder this problem or hinder this alignment. Complication of transoral approach, damage to the eustachian tube, hypoglossal nerve, bleeding, severe tongue swelling, palatal and the pharyngeal dehiscence, retropharyngeal abscess, neurological worsening, aspiration, CSF leak, meningitis, delayed pharyngeal bleeding, and craniovertebral junction instability. Complication of the craniovertebral junction fusion surgery such as neurological worsening, vertebral artery injuries, bleeding from the vertebral venous plexus, craniovertebral junction instability, cord edema, CSF leak, meningitis, non-union, hardware failure, and sudden death. A few of common complications of posterior fusion surgery can be mechanical failure, include non-union, instrument failure, adjacent segment degeneration. The C1 C2 facet joint is the most critical area for assuring good fusion and undertaking kyphotic correction. Subaxial kyphotic deformities has been observed following laminoplasty and the wider detachment of deep extensor muscle. Therefore, it is imperative to avoid occipital fixation to minimize such risk and to ensure the preservation of occipital and C1 motion. Here, I want to mention again that occipital neuralgia can occur following C-root resection but has not been observed for the many affected patients. So the neurological worsening is most commonly observed during vertical reduction, and this risk increase among the patient with T2 signal image in MRI and reduced canal diameter. This can be prevented with the adjacent use of the intraoperative neuromonitoring, so you can avoid these kind of neurological worsening. Dysphagia, especially following the military tuck positioning, that can lead to the glossoptosis, and this is also increased among the patient with the occipital cranial fixation in retractor posture. This is the enhancing healthcare outcome, the basilar invagination, or we can say here the basilar invagination is infrequently found in isolation, poses significant treatment challenges, and before any treatment specific to condition, practitioners should be screened for the other associated anomalies. Advancement in the diagnostic technique have facilitated the management of the condition, and patients with reducible invagination potentially can avoid combined anterior and posterior approach, require only posterior decompression and stabilization. The most appropriate surgical approach and fixation choice will likely remain controversial, and until high-level randomized trial can be elucidate the post-effective treatment course. So the enhancing healthcare treatment outcome, basilar invagination is a rare neurological disorder that may be found in isolation and poses significant treatment challenges. Because of the complexity of the management, it is best managed by the interprofessional team, but includes the neurologist, neurosurgeon, ICU nurses, therapists, and the radiologist. Before any treatment is specific to the invagination, practitioners should screen for the associated condition and try to avoid compromising potential surgical treatment for the invagination. Advancement in diagnostic technique have associated with the management of this condition. Patient with reducible invagination potentially can avoid a combined anterior and posterior approach, requiring only posterior decompression or stabilization in somewhere. So the most appropriate surgical approach and fixation choice will likely remain controversial, and high-level randomized trial can elucidate the most effective treatment course in the future. Irrespective of the type of surgery, some rehabilitation is required for the patient. Beside the physical therapy, the speech therapy and the occupational therapy are necessary to regain the function of the muscle, and the social worker should be involved to ensure that the patient home environment is safe and support systems are available, and the neurology nurse should follow the patient to ensure that the patient is not worsening. Upon communication between the interprofessional team member is vital to improve outcome. So here I am concluding my topic, which it was not easy to present in front of you people, because it is really tough to explain and conclude, but I tried my level best. I hope you will like it. If you like it, please share it, subscribe it, and give us your comments. I'm trying to get better for the technology and my presentation and my accent, everything I'm trying. I hope you will like that. Thank you so much.